Hey everyone, welcome back to the first annual People of Color Living with Diabetes Virtual Summit. So today we have with us Dr. Stephen Ponder to talk about all things diabetes. So thank you so much, Dr. Ponder, for being here.
Thanks, Casey. It's really a pleasure to be here and talk to you this morning. Thanks for having me.
Yeah, definitely. So could you give a little bit more information about you and your background?
Well, you know, I'll just be honest with you. I'll be transparent on my age. I'm 63 years old. I'll be 64 next September. I've had type 1 diabetes, which we'll talk about in a few minutes, for over 55 years. I'm a pediatric endocrinologist, which means I'm a specialist in disorders, including diabetes, in children, and I've taken care of adults as well in the past. I'm what they call a certified diabetes educator, although the terminology has been slightly changed in the last couple of years. I've had that title since 1989, and I've been board certified the same period of time in pediatric endocrinology. I also am a person of color. I'm a Native American. My tribe is based in Iowa. It's the Meskwaki tribe, and I and my children are enrolled members of the tribe. So I've seen the impact of diabetes on populations of color across the United States, especially in my people, the Meskwaki Indians, and of course others that I've cared for in my practice, whether it's been in South Texas, Central Texas, or West Texas. And I'm really honored that you gave me the opportunity to try to clarify some things about diabetes this morning during this session. So thank you very much for having me.
You're welcome. Thank you for being here again. Okay, so let's get into it. What's the difference between type 1 and type 2 diabetes?
Well, that's the big question. Whenever anyone comes into diabetes, they've just heard the word, and they often know somebody in the family or a friend or some casual relation who has that condition, or they see some advertisement now on television. So the word diabetes is certainly nothing new to the average person in the United States, or anywhere for that matter. But the types of diabetes often get very simplified into the numbers 1 and 2. And so for the audience, I will give you the broad definition of what these are. And keep in mind, during the course of our discussions, we may drill down a little bit more into some differences between these forms of diabetes. But generally speaking, type 2 diabetes is the one that most people have some reference or some exposure to. That's typically what used to be thought an adult form of diabetes, but now we know full well through lots of experience and research that type 2 diabetes can also affect young people. People as young as 8 or 9 years of age can develop type 2 diabetes. It's unusual and it's not common, but it does happen. So generally speaking, type 2 diabetes is associated with being older. Oftentimes it affects people of color, although certainly it affects people of all colors and all races. It's associated with a medical condition, or more of a metabolic condition known as insulin resistance. Insulin resistance. And you may have heard this term before, but insulin resistance is very prevalent in the population. It's estimated that about 1 in 4 people have insulin resistance. Well, we know full well that 1 in 4 people don't have type 2 diabetes. So insulin resistance is the foundation, if you will, upon which the house of type 2 diabetes is built. Not everybody has a house built on that foundation, but it's the insulin resistance that is the first step towards the development of type 2 diabetes. So in people with type 2 diabetes, insulin resistance creates a strain on the body's ability, excuse me, to produce enough of the hormone insulin. Now, insulin is important because it's a hormone that helps the body absorb and metabolize the glucose or sugar that our body absorbs from the food we eat, whether that's from a carbohydrate source, which is generally mostly ultimately converted into sugar, or even other nutrients such as protein or fat. All of the three major macronutrients, whether it's carbohydrate, protein, or fat, can in portion or completely be converted into sugar or glucose, with carbohydrates being the most common. The inability to properly store and metabolize the glucose that comes from these macronutrients is really the fundamental problem we call diabetes. And in the case of type 2 diabetes, it's because the person does not produce a sufficient amount of effective insulin. And I have to explain this more carefully. Resistance is the problem. And the body usually has the ability to produce more insulin in the face of the resistance, much like a car going uphill will go into a lower gear if it has an automatic transmission to maintain the same speed. So it puts more strain, if you will, on the source of that insulin, which is the pancreas, and everything's normal for the time being. Now, ultimately, people with type 2 diabetes, their pancreas loses the ability to make enough insulin to compensate for the resistance. And if the resistance continues or even gets worse, and resistance can get worse over time, then at some point, the ability to produce insulin begins to fail, begins to diminish. And the resistance, the effect of the resistance takes dominance. And when in the face of that resistance, the blood sugar levels can't be controlled the same way they would be otherwise in a normal, healthy situation. And it's that inability to regulate sugar levels properly, which is the definition of diabetes, whether it's type 2 or the one I'm about to talk about next, type 1. Now, let me shift gears and talk about type 1 diabetes. Type 1 diabetes, in a sense, is due to the same process of type 2 in regards to the inability to manage blood sugar levels, but the cause is different. In type 1 diabetes, the person has lost the ability to produce insulin. It's not that they have significant resistance necessarily, which they can, but it's that they've lost the ability to make and produce insulin. The usual reason for that is typically the immune system of the body creates a response against the cells that make the insulin. We call that an autoimmune or an autoimmune response, which slowly, gradually attacks the cells in the pancreas that make the insulin. And as the ability to produce the insulin from the pancreas begins to diminish and fall, even in the absence of any insulin resistance, the body cannot maintain normal balance of blood sugars from the food that person is eating. And of course, then the blood sugars go up high, they become elevated, and then the diabetic state is attained. Now, between type 1 and type 2 diabetes, there's a proportionality there. The majority of people with diabetes in the world have what's called type 2 diabetes. That's estimated to be about 85 to 90% of people. The other 10 to 15% are people that would have what are called type 1 diabetes. So by far, more people have type 2 than type 1. Now, what blurs these margins is that some people believe that insulin therapy in the form of injections or an insulin pump are only used for people that have type 1 diabetes. Nothing could be further from the truth. Often, insulin therapy is necessary for people with type 2 diabetes, sometimes as early as when they're diagnosed, but certainly as their diabetes progresses over years to decades, insulin therapy might be required. So that's one reason that some people may see this old terminology called insulin-dependent diabetes and non-insulin dependent diabetes. Those are now antiquated terms. They're no longer used because whether or not you need insulin does not define, nor does it redefine what type of diabetes you have. You either have the autoimmune form of diabetes or you have the insulin resistance associated form of diabetes, as I talked about initially. So those are, broadly speaking, the two types of diabetes. And as we discuss a little bit further in this session, you'll find there's some subtle differences between those two that we might have some time to chat about.
That's so interesting. So there are more types of diabetes, right? Could you kind of explain the difference of LADA and Moody?
Right. Now, if you take a step back and one of the things I mentioned was diabetes is an inability to properly manage or regulate one's blood sugars, right? It's in your automatic systems in your body are unable to do this. Now, if you take that broad umbrella style definition of diabetes, we have type 1, where you lose the ability to make insulin, and insulin is a very important part of the ability to maintain sugar control, or you have resistance, and resistance fights the insulin that's there to the point that it overwhelms it, and you can't control diabetes because of that. But as you mentioned, there are other types that are broadly described, and I'll discuss those next. One is called genetic diabetes, or the term is monogenic, M-O-N-O-genic, monogenic diabetes. And that is where we have discovered that there are very specific genetic defects or mutations, if you will, in the pathway, the chemical pathway by which insulin is produced and or released inside the pancreas. These are specific genetic abnormalities. Now, collectively, they've described at least 8, maybe 9 of these as of late. Some of them are exquisitely rare. A few of them are fairly common. Collectively, the monogenic forms of diabetes go by the name MODY. It used to be called maturity onset diabetes of youth, MODY. Monogenic is a relatively new term because MODY was a term that was described in the 1950s, and we didn't discover these genetic causes until the 1990s, and we realized then we could relabel them and call them monogenic. So I guess you could retain the MODY title if you want to, but you'll hear the word MODY, M-O-D-Y, maturity onset diabetes of youth, or you can also now use the term monogenic. Those individuals have a different approach to their therapy compared to type 1 and type 2 sometimes, and in fact, in some cases, may not need therapy at all under certain circumstances. So it goes beyond what I can talk about in our brief session here, but MODY diabetes is estimated to account for maybe up to 5% of all patients with diabetes. And what happens there is people with type 1 or type 2 diabetes may be misdiagnosed with type 1 or type 2, when in reality, they actually have MODY diabetes, M-O-D-Y. That's because the genetic testing for MODY is not easy to get, and the physicians that diagnose these patients don't think of MODY first when they see the diagnosis of diabetes. They see either type 1 or type 2. It's sort of a black and white type view of the world. So that's one type of diabetes, MODY. Another very broad type that it's important to appreciate is one called LADA, or LADA, L-A-D-A. And that word stands for latent autoimmune diabetes of adults, LADA. And what LADA is very similar, if not close to being identical, to type 1 diabetes, which traditionally is thought to occur in younger people, in children and teenagers, but LADA can occur in adults. And it's an important thing to remember that half of people with type 1 diabetes, and LADA is a form of type 1 diabetes, half of the people with type 1 diabetes develop it after age 30. After age 30. It's not something we really think it doesn't make a lot of sense to people because they're used to thinking that type 1 diabetes, which I said earlier is called insulin-dependent diabetes, it also carried an older term called juvenile diabetes, that type 1 only affected young people. It only occurred when you were young, and type 2 occurred when you were old. And just as I said, type 2 diabetes can occur in younger people. Type 1 diabetes commonly occurs in adults. It just goes by a different term. It's called LADA, L-A-D-A. People with type 1 diabetes in adulthood are often normal size. They're not overweight. They may not have some of the typical findings or appearance of a person with type 2 diabetes, who may often be overweight. And just simply because of their age, they're assigned the diagnosis of type 2 diabetes, which is a misdiagnosis in many cases. I have several patients I've taken care of before who were diagnosed as having type 2 diabetes, when in reality they had LADA, L-A-D-A, which is a form of type 1 diabetes, and they were put on the wrong therapy. And by being put on the wrong therapy, that had consequences. That had things that happened to them, which included diabetic ketoacidosis in a couple of cases of patients that I know, and I know of others who have had similar problems from being misdiagnosed with type 2 diabetes when in reality they had type 1, but they were simply told they had that based on their age and that they were adults, and nobody checked for the presence of LADA blood markers. So those are two of the other broad forms. There are some other smaller forms, such as one called secondary diabetes, and that's when your pancreas has been damaged by, say, cancer or by disease, by alcoholism, or by trauma, or by conditions like cystic fibrosis, which will damage the pancreas. And the source of insulin, as I said earlier, is the pancreas. So if it's been damaged in some way by an external, force or disease, then of course you'll have diabetes. But the term they give for that is called secondary diabetes, because those people do not necessarily have insulin resistance, nor do they have any evidence of autoimmune forces attacking the pancreas. Quite frankly, Casey, there are several others, and I won't go into detail because we could spend all day talking about all the various subtypes of diabetes. But you get my gist here, which is that diabetes is far more than just purely type 1 or type 2.
Yeah, and I've even heard that there's now a type 3 diabetes with Alzheimer's and everything like that. So, now it's 2020 and we have been able to find all these different types and change the names and find all these amazing technologies to help us. Is there a cure for diabetes now?
That's the question everybody wants to know. It brings up an existential discussion I like to have with patients about what is a cure, and what are our expectations for a cure. For one, we tend to think of cures in regards to infectious diseases. Like right now, in the midst of our COVID pandemic, we see cures as medications that we could take, not the same as vaccines, but a cure is something that eliminates a disease from my body. It makes it go away completely. So if we apply that same approach to diabetes, what is a cure, and what are our expectations of it? Well, for one thing, most of us would like a cure to be fairly quick, that does not require a lot of time. Most of us would like it to be something that's not very invasive. It would be great if I had a pill or at most a shot that might do that. Many of us would like it to be free of any side effects. I don't want to have any side effects to my cure whatsoever. Thank you very much. And then a fourth one, which is kind of an economic concern, is we want whatever cure we get to be totally free or given out by the government, or something that we can just kind of get at the corner drugstore. And I think those four things, when you sit and think about it, just don't add up. A cure is not something, a cure for diabetes for type 1, for example, is not something we just have, sitting on a shelf somewhere. So the argument that I'll make to you is that there is technically a cure. It fulfills that definition. It's called a pancreas transplant. Let's frame that in regards to what I just told you a second ago. A pancreas transplant is highly invasive. It has lots of side effects. It cures diabetes. It's very expensive, and it requires a long-term administration of medications, a handful of pills you have to take every day to keep the pancreas from being rejected by the body. Okay, but technically that's a cure. The people that get pancreas transplants, and sometimes they get a kidney associated with it, don't take any insulin anymore. They don't have diabetes, but they have consequences to that cure. So it's interesting when that question is brought up, because implicit in the question is, I want a cure that's not a pancreas transplant, even though there is a cure for that. Okay, so that's the first response I want to give to that question. But there is no cure for type 1 diabetes outside of a pancreas transplant and all the things that go along with it. There are many, many, many ongoing studies that are trying to slow down how type 1 diabetes progresses inside the body, such that if somebody's recently diagnosed, could we do something to slow down how quickly the diabetes progresses inside? Because when you're diagnosed with diabetes, it's often at an early stage, in the relatively early stage, where you could possibly stop some things from moving forward in type 1 diabetes. So yes, there are some exciting research opportunities out there that are trying to keep the body from losing all of the pancreas, all these cells of insulin, all the insulin cells that produce, the cells that produce insulin in the pancreas. There are research studies aimed at doing that, and they're showing some encouraging results. They typically are things that involve expensive medications that have potential side effects, though, but they're not necessarily invasive like a major surgery to put a new organ in your body. Mm-hmm. So, but there is no simple cure for that. Now, let me shift gears and talk about type 2 diabetes. Type 2 diabetes is much more complicated in regards to the concept of a cure. It is well known that early on, after you've been diagnosed with type 2 diabetes, if you're relatively new in your course, certain things that you do, certain changes you may make in your self-care behavior could turn it around and get you to a point where you would not need to be on any outside medications or therapies, and you could manage it entirely by how you live your life, your lifestyle. Nevertheless, one other concept that people don't appreciate with type 2 diabetes is that it is a progressive disease, okay? I mentioned earlier in discussing the disease itself is that you have insulin resistance, okay? You have resistance on the one hand, and you have a supply of insulin on the other. Well, the insulin resistance generally is a constant, or it can even go up. You can reduce it, and that requires physical activity. Certain medications might help with that. Weight loss, exercise, those things can help lower the resistance. But the supply side of that equation tends to be more of a downhill slope, in that when you're born, you have 100% of your ability to make insulin. And when you get type 2 diabetes, you're starting to slowly dwindle that down, and you don't get a recovery of that. You don't grow back a full set of insulin producing cells in your pancreas. So you're diagnosed with type 2 diabetes. In 5 to 10 years, you've actually lost more insulin production than you had when you started. 10, 20 years out, you lost even more. And so at some point, even if you lowered the resistance, you may have still lost a significant proportion of your ability to make insulin. In fact, it's been estimated, and this is just a figure, is that when you are diagnosed with type 2 diabetes, at the time you're diagnosed, it's thought you've lost about 80% of your God-given ability to make insulin at that time. And so you've got another 20% to live off of for whatever the remainder of your life is, if you want to try to avoid insulin therapy to stay alive. That's a sobering number when you think about it, because that 80% is permanently lost. It's not felt to be anything that will recover or come back. And if you get the diagnosis of what's called prediabetes, it's estimated you've lost about 50% already. Now, prediabetes means you don't have flat out diabetes, but you have measurable abnormalities in your blood that suggest you are going to get diabetes in the next 5 to 10 years.
Okay. I didn't realize, type 2 was like a progressive disease. I've always heard, get control of your weight and your diet and you're going to be good. So that's really interesting. So you've said, in the past, just take a pill. So do I have to take insulin, or can I just take a pill to help manage this?
Well, depending on the type of diabetes and the stage of diabetes you're in, there are pills out there for people with type 2 diabetes, and have been for decades, that can help their body produce more insulin. Because as I said before, look at it as a supply and a demand issue. The supply of insulin can be increased with certain pills, okay? The resistance also has oral medications that you can help lower your resistance, that come in the form of pills, or injectable medications now, as many people are aware of, that they can attack the problem from both sides of the equation, by the demand side, by lowering the resistance, or by the supply side, by increasing the output. And so that's where you're going to see all the medications play a role, either alone or in combination, either playing a role at the supply or at the demand, or a little bit of both. And so with all the dozens of medications out there are for diabetes, that summarizes in a big picture how they all work. The pills that are out there, like I said, some of them will make your body produce insulin output. Some of them will lower your resistance to the insulin you take. And sometimes they're taken in combination with each other, so you get a 1-2 punch against the diabetes. As far as type 1 diabetes goes, there is not really a pill right now that's effective that can be used to produce insulin. And I think you and I both know for decades there's been research aimed at trying to develop pills for insulin or an oral form of insulin. And that research has not stopped. From time to time, I'll see reports of a new oral insulin attempt where they're trying to get some new preparation where your body you can take a pill and you can get insulin in your body. The problem with insulin pills is that they have to get through the stomach, and the stomach is loaded full of acid, and acid totally tears up insulin. And so if they have to find a way to protect the insulin that would be in a pill and get it into the intestinal tract, which is not acidic, the small intestine, and where it could be absorbed. The other problem you run into is making sure that you get a consistent release of insulin that best matches your particular needs. And that too is a problem, because our body's insulin requirements, with or without diabetes throughout the day, are constantly shifting up and down. And a pill would not have the ability necessarily to do that. There have been some studies trying to develop something called a smart insulin, which is an insulin that activates itself based on the blood sugar level. That's been in development for years, but nothing practical has come out of that quite yet for the smart insulin. Because one of the risks of insulin therapy is low blood sugar, what we also call hypoglycemia. If we get too much insulin, more than we need, and we can't turn it off because it's being given as a shot or a pill, then one of the consequences of that is low blood sugar, which could affect our ability to think and move and all sorts of other things that would be very dangerous to our health and well-being. So pills are wonderful alternatives because they're not injections for a lot of people who don't like shots or pointy things. But unfortunately, we don't have anything useful right now for type 1 diabetes, yet there are quite a few different oral medications or pills available for type 2 diabetes. But the caveat to remember is, even if you have type 2 diabetes, over the span of time, it's not unusual to where pills stop working, because the pancreas is slowly losing its ability to make insulin over years to decades. And if you live with type 2 diabetes long enough, you get to a point where you can't take pills or any other medications to beat a dead horse, for lack of a better metaphor, and to make any more insulin. And you only can then take insulin by an injection or an insulin pump at that point.
Yeah, I guess Afrezza has been the most successful inhalable insulin so far.
Well, and I'm glad you bring that up. Inhalable, yes. Inhalable, there were insulins before then as well that were inhaled. The contraptions that were used to inhale them were a bit challenging, but Afrezza is a more recent entry into the market, which is very rapid in its onset. It's absorbed through the lungs. It provides an immediate insulin surge. It's not used for people who need a long-acting insulin effect. That's called a basal insulin. Inhaled insulin is not an option for that, but it is an option for when somebody sits down to have a meal, to eat food. That's its main usage. But injected insulin is used also for basal needs, and there's a different formulation for that. There's several different formulations. And so that's important to make that distinction between mealtime insulin and basal insulin. They're two different types.
Yeah, and I haven't used it yet, but I have seen some friends, like, they're using their pump as their basal, but then when they need, like, they've had a stubborn high, or they just need something to be super rapid, because Afrezza is, they take it to kind of help with a stubborn high or something. So that's what I've seen it being used for. So is diabetes hereditary? I've heard that before.
Yes, it is. It's hereditary in different ways. Keep in mind that I mentioned I'll go to that previous discussion on monogenic diabetes. Clearly, the term itself says it's hereditary, monogenic. It means it's a genetic form of diabetes. People that have monogenic diabetes, albeit it's 5% or less of the total diabetes population, typically have a parent with that condition, and they have another parent beyond that, so a parent, a grandparent, along a chain of a genetic chain going back at least 3 or 4 generations that have that form of diabetes. So that's the ultimate genetic diabetes, are the various forms of MODY. Now, in regards to type 1 and type 2 is also genetic, in that if you have a family member with it, whether that's your mother or your father, then you carry roughly a 50% risk of having type 2 diabetes in your lifetime. So it doesn't guarantee it, because diabetes is in type 2 form is going to be a combination of your genetics and the way you live your life, your environment, things that are not just strictly controlled by genes, environment as they call it. So genetics are very strongly influencing type 2 diabetes. And so if you know that, then, and if you're a proactive family, then you might be able to try to engage in certain lifestyle behaviors, which might help you reduce the likelihood of developing diabetes. It's not a guarantee, but it's something that mindful people that hear this could decide they want to do to minimize their or their children's risks of developing type 2 diabetes at some point in their life. And those are lifestyle modifications that we can talk about at some other time. Type 1 diabetes is also genetic in the sense that you inherit the susceptibility to get it. It's well known that type 1 diabetes has certain triggers that make the process occur, and they're different triggers, and they're trying to get them all listed out, but there's some that are relatively well known. Certain infections, certain foods, certain environmental things that are described in the literature are associated with developing type 1 diabetes in susceptible individuals. But you carry a gene or a series of genes that make you more likely to be susceptible to that condition. The numbers are like this. In the general population of people in the world, there's about 3 people out of 1,000 that will develop type 1 diabetes. 3 out of 1,000, randomly. If you just take a random sampling of 1,000 people, you would be expected to find roughly 3 of them that would have type 1 diabetes. Now, if you have type 1 diabetes, your risk of your offspring having it is about 10 times higher. Now, 10 times higher sounds very scary, but remember the baseline number, 3 out of 1,000. 10 times is 3 out of 100. It's usually about 4 or 5 out of 100, depending on the gender of the parent, such that if it's the father, it's generally 5 to 6% of his children would be expected to, the risk would be 5 to 6% for his kids, okay? And if it's the mother, it's 4 to 5%, okay? So those are the general rules of thumb. If you're identical twins, if you have an identical twin, your risk is about 35 to 40%. Again, that speaks to a role for genetics in that diabetes. So genetics does, and they say that, genetics, there's a catchphrase for this, genetics rolls the dice, in the environment pulls the trigger, in diabetes. And that's an old phrase, and it's used in many other contexts. But genetics does set the table for this, but it doesn't mean with absolute certainty that you're going to get it. Okay, so genetics does play a role, and it generally plays a role in your risk for getting the condition.
Gotcha. So am I still able to have healthy children? Am I able to have a good, healthy pregnancy?
That's a very common question. Can I have kids? Well, certainly from the male perspective, yeah. I mean, that's not an issue. From a female perspective, yes. The answer is women with type 1 diabetes or diabetes in general can have healthy pregnancies. The way you accomplish this is by working very diligently to maintain the best management, you want to use the word control, over your diabetes for a significant period of time prior to conceiving. Now, that doesn't always happen. I realize that. Sometimes pregnancies are surprises. But if you go into a pregnancy as a planned event, then the recommendation is to maintain a period of optimal, ideal, best you can do, blood sugar control for at least 6 months, before conception, okay? And then you will always be managed by the obstetrician as what they call a high-risk pregnancy, which means you get a little bit more time and attention by the physicians to make sure that you're maintaining your blood sugar control as a mother during the pregnancy, which often means frequent blood sugar monitoring, or in this day and age, continuous glucose monitoring, maybe an insulin pump, maybe not, just depends on the style of the doctor and the wishes of the parent. But a sustained period of good control is really essential to minimize any risks to the mother, as well as certainly risks to the infant, to the newborn. And in cases where there's not a period of optimal control, there is a higher risk of potential birth defects and miscarriage in those situations. And unfortunately, I've seen that happen all too often. And so it's something that's a mindful person that's contemplating having a family and has any form of diabetes should entertain when they're moving forward with family planning. And after saying all this, I can tell you I know lots of individuals who've had very healthy pregnancies and successful pregnancies and have large families and have had both forms of diabetes. So it should not be a deterrent, even though it is a bit of a challenge to do it right.
Okay, yeah. So is diabetes my fault?
That is the number one question that I get asked when I go into the hospital for the first time or to see a newly diagnosed patient or family. And that is, oftentimes we feel a compulsion to assign, I want to use the word blame or cause or some reason as to why am I in this situation. And that's a natural human tendency. And some people are more inclined to want to focus that blame inward than they are outward. And so you see that breakdown in when you're working with families. What I tell people, in fact, it's the very first thing I tell people after I introduce myself to them, is that they nor their child did anything to cause the diabetes. And I think that's essential because you cannot effectively teach, educate, or motivate people if they start out of the gate with a serious guilt syndrome about diabetes. And I've mentioned earlier in the discussion about there are genetics involved, there are some lifestyle behaviors, but even people who engage in what you would consider behaviors that would predispose to diabetes don't get it. That's not a guarantee. So the first and most important thing is to diffuse, squash, whatever term you want to use, what I call the guilt monster. And I really pound that home with the families, so much so that I can see in my mind the relaxation of the shoulders of mothers and fathers where I tell them this at the bedside when their son or daughter is in the ICU in diabetic ketoacidosis with a new diagnosis of diabetes, because they felt that they've done something wrong or somehow they brought this on their child. So that is an essential first message everyone should hear when they hear the word diabetes as a diagnosis, is you didn't cause this, but you can take charge of it. And I think that's where the focus should be placed.
Yeah, and I definitely think that's something that we need to be reminded as well. There's the diabetes burnout and just getting tired of doing it. So just being reminded that, to diffuse the guilt monster whenever it kind of comes up. That's, yeah, definitely a good reminder. So would you consider this a disability?
That's a great question. The view that we have as a society of disability and the view we have as individuals of a disability are not always in sync with each other. And I know that certainly there are laws that have been passed, like the Americans with Disabilities Act in 1990, and in a series of other laws that have come after that over the last 30 years, have created a public mindset and an institutional mindset that diabetes is a disability. Now, and so yes, it's considered a disability under certain legal definitions of what disability is. Now, when we look at the broad scope of what disabilities would involve, many of us think of physical disabilities. Many of us think of mental disabilities. You know, if you want to call this a metabolic disability, I don't usually hear the word metabolic disability thrown around a lot. It's usually involved with physical health or mental health. But in some ways, you might say we have a metabolic disability, if there was such a term. And from a personal standpoint, we look at our disease, I think, differently. You know, I know you've had diabetes like I have for quite some time, yet I don't walk around, nor do I wake up in the morning considering myself disabled because of this condition, okay? So that's a personal choice that I make. I can't keep you, Casey, from thinking that you have a disability because you're diabetes, because I can't tell you how to think. I'm not going to tell you what to think or how to think. All I can do is explain things to you. But from my standpoint, I feel, for me personally, that if I get up in the morning and feel and act disabled, then I'm probably going to act that way the rest of the day. If I feel empowered and capable, that's hopefully how I'll act the rest of the day. I won't feel like the diabetes is weighing me down. Is it something I need to pay attention to? Absolutely. Is it something you need to pay attention to? Absolutely. But the term disability has several different faces to it. And of course, the public face that we talked about at the beginning is that there are certain rights, I guess you might say, that we have by virtue of having this metabolic disability that we share in common, those rights with people with physical disabilities and or mental health disabilities. But on a personal day-to-day basis, I personally don't consider my diabetes under normal circumstances a disability. And that's my personal feeling. But I completely respect the right of anybody out there with diabetes to feel otherwise. And because how we feel is a personal choice. I try to encourage people to feel more empowered because I think empowerment is the pathway to the best possible outcomes. But that's me. And some people may not share that feeling. Some healthcare providers may treat people with diabetes as if they're broken or somehow less than other people. I think that's wrong. Personally, that's my belief. I think it's just another source of discrimination that anyone with color just doesn't need. You know, we or anybody for that matter, color or otherwise, we just don't need any more sources of discrimination. You know, heaven knows we spend too much time trying to classify and subclassify each other as it is, and we need to do less of that, in my opinion.
Yeah, very true. Well, Dr. Ponder, thank you so much. I think that's all of my questions I have. Do you have any other thing you would like to add?
My spontaneous answer to that is that people with diabetes of any creed, race, background, orientation can live highly successful, productive lives. I see it all the time. I would hope and pray that diabetes does not become an impediment to them. And I'll say this to people in the clinic when they come in. Metaphorically, we can put our diabetes in 3 different positions relative to our lives. And I'll explain this. We can either put it in front of us like a barrier and use terminology like, well, I can't do that because I have diabetes. Or I can use it as a barrier, a block, an excuse if you like to use it as that. But I see some people throughout the span of their lives use it as a reason why they can't do certain things. That's one way of living with diabetes. The other way is you put it behind you, out of sight. You don't even notice it. You don't pay attention to it. The metaphor there is you're really not paying attention to it at all. You're doing just the bare minimum, if that, to stay alive, to get through the day. And so both using it as a barrier or ignoring it are both positions in your life which I don't think really serve most of our needs very well. On the other hand, the third position, which I strive to get patients and people to do, is to put it at your side. You know, put it either one side or the other as your sidekick, if you will. Now, obviously, it's a sidekick you may not have wished to have, but you have to find some way to tame it, like you would a pet on a leash, to do what you need to do. And the better you tame your diabetes and you can keep it, under control, the farther you will go. This more safely you will get there as well. So it's important to remember that. That's a key theme here, is where do you put your diabetes in relation to your life? A barrier, or do you just ignore it? Or is it at your side and have you tamed it? Are you continuing to tame it? Unfortunately, you can't make it just totally go away and make it disappear. That's a realization that most of us get to after hopefully a really short period of time, that we just can't wish it away or think it's a bad dream or just ignore it away, because we do that at our own peril.
Mm-hmm. Yeah, that's so true. Well, thank you, Dr. Ponder. I've known you for a long time, and every time I talk with you, I learn something new. So I really appreciate you being here with us today and answering all these questions. So thank you so much. Thank
you, Casey. It was a pleasure to be here today. You have a nice day and a nice weekend. Thank you.
Thank you. You too. Thank you.